And for anatomy, there's a few different things we need to discuss for the liver. So we'll start with blood supply and some of the associated conditions that you have to recognize. The first thing you have to remember is that the liver receives blood through two different sources, and these are both part of our portal triad. It can receive it through the proper hepatic artery, and it could also receive the excess blood that comes through the portal venous system. So let's look at the proper hepatic artery first. So how that works is the blood will flow from the aorta. Because we're talking about a foregut organ, the liver, it'll go through the celiac trunk into the common hepatic artery, then to the proper hepatic, and finally into the liver. If we look at a pictorial representation of this, we have our aorta, and then it'll go to the celiac trunk, which is this area with all three branch points. And then it'll go through the common hepatic artery, proper hepatic, and then the blood will finally reach the liver. In addition to receiving blood through the proper hepatic artery, the liver also receives blood supply from the portal vein. And most of our GI tract actually drains into the portal system. So this blood should be deoxygenated. It has a lot of nutrients and other supplements that were absorbed in our GI tract as well. So if you think about it, you don't want all of that stuff instantly entering the systemic circulation without any sort of checkpoint. So the liver kind of acts at that as that checkpoint and can metabolize certain substances prior to them entering systemic circulation and potentially causing some damage. How this works, you'll have your portal vein draining into the liver itself, and then within the liver, that'll drain to the hepatic vein, and from the hepatic vein, it'll reach the inferior vena cava, which is our main vein that brings blood back to the heart. And we'll show this pathway a number of times as this lecture moves forward today. And you can see the portal system, it's draining venous blood this way and all the way up into the liver. And we can show it in a little bit of a different way. If we have our blood supply flowing from left to right, you have your portal vein, liver, hepatic vein, and IVC. And I like showing it in this diagram because we can start talking about some of the clinical conditions and the subsequent effects of those conditions. So here's some relevant conditions. We're going to talk about the first three conditions right now because it relates most to this blood supply. I will mention portal hypertension much later. I go into great detail about portal hypertension and all of the sequelae of portal hypertension when we talk about the liver cirrhosis later on in the condition section. So keep that in mind. We'll start with Budd-Chiari syndrome though. So Budd-Chiari syndrome is a thrombosis of the hepatic vein. So if we go back to our diagram, it's going to be a thrombus forming in this region here. And this is a very rare case. It happens in about 1 out of every million people. And it's going to be associated with people who are hypercoagulable already, which makes some sense if it's a thrombosis. Your symptoms you're going to get, there's something that you really have to know. This applies to both Budd-Chiari syndrome and right heart failure. You're going to get something called a nutmeg liver, sometimes called congestive hepatopathy. And you can also find that if somebody has Budd-Chiari syndrome, they're going to be in severe abdominal pain. Their liver can be very, very enlarged. They could have ascites, which is like fluid in your cavity. And all of this is caused by a backflow of fluid. So let me show what I mean by that. What's going to happen is that if you have this thrombus here, you're going to have your blood supply trying to get past this thrombus, but since it can't, everything's going to build up and you're going to get fluid that's just stuck behind it. So you'll get liver congestion. You also get portal venous congestion as well. This is a picture of what a nutmeg liver looks like. On the top right is a picture of an actual nutmeg, and you can see some of the similarities here. And this is a hallmark of congestive liver disease. So if your liver is congested in the sense that it has a lot of fluid that's backed up in that area, it'll look kind of like this. And you can see the similarities between the two. And this can be caused by only a couple things. Right heart failure is the most common cause of nutmeg liver. And obviously, Budd-Chiari syndrome, as we just talked about, can also cause it. Something I want to talk about is how do we tell the difference? Let's say we have a patient who has congestive hepatopathy, and we haven't like done an echocardiogram or done anything like that to measure pressures as well. How can we tell Budd-Chiari from right heart failure on a question stem, especially? So what can happen here is that in Budd-Chiari syndrome, you don't get something called jugular venous distension or JVD. So jugular venous distension, as the name suggests, is distension of your jugular vein. And that's going to happen when any of your veins are congested. Um, your IVC is one of your main veins as well. So if your IVC gets congested, it's likely that your jugular veins will also get congested. It's because that. So let me show you what I mean. In this case, in Budd-Chiari syndrome, notice how our IVC is distal to the thrombosis. So because there's nothing actually making it to the IVC, there's not going to be any jugular venous distension. Let's contrast that with right heart failure. So remember that our IVC is the main, this and the SVC are the main veins that drain blood back to our heart. So here's a picture of our heart here. Let's imagine that our heart's not working at all. So if our heart's not working, then fluid will back up proximal to that as well. So in addition to liver congestion and portal venous congestion, you're going to get congestion of your hepatic vein, congestion of your IVC, and congestion of your jugular veins. And because of that, this congestion here, you will see jugular venous distension in right heart failure. So on question stems, keep a lookout for that. If they mention any sort of JVD, which is like pulsating, you can see congestion in the neck essentially. And they'll just usually on a question stem tell you yes or no if they have JVD. Another thing I want to talk about, now that we've talked about Budd-Chiari syndrome and right heart failure, I want to discuss portal vein thrombosis. So imagine if you have a thrombus in this region here, it's only going to cause portal vein hypertension and congestion. So as you can see, if nothing's coming through, you're going to get a lot of backflow in the portal system directly. But it's important to realize that the liver is unaffected. There's no congestive hepatopathy. So again, that's another differentiating factor if they ask you on a question stem, basically saying that somebody's got all these problems. Maybe they have ascites and portal hypertension, and you're trying to figure out what's going on, and you realize their liver is completely normal. I want you to at least consider portal vein thrombosis as a potential cause. Now let's talk about the portal triad, which we've discussed in previous lectures. This is located within the lesser omentum, located here, and it courses through what's known as the hepatoduodenal ligament, which connects as the name suggests, connects the liver and the duodenum. There's three structures you need to be aware of: the proper hepatic artery, the portal veins, and the common bile duct. So the Pringle maneuver, which we discussed in the small intestine lecture as well, is a maneuver that some surgeons can do if they notice abdominal bleeding, especially if the bleeding seems to originate from the liver. The Pringle maneuver can help determine whether this is due to one of the vessels in the portal triad, or if it's due to something like the hepatic vein or the IVC instead. So you can clamp the hepatoduodenal ligament, and what that'll do is it'll clamp blood flow to the portal triad, which we just discussed consists of the proper hepatic artery, the portal vein, and the CBD. So I'm going to draw our framework that we just used for Budd-Chiari syndrome and right heart failure and portal vein thrombosis. But I just want to remind us that in addition to the portal vein draining to the liver, we also have the hepatic artery. So it receives through these two sources. But keep in mind that if there's a liver bleed, it doesn't necessarily mean it has to come from these two sources. It could actually be originating more distally in the hepatic vein or the IVC. So what the Pringle maneuver will do is it'll block flow to the portal vein and hepatic artery. And if you notice that there's still continued bleeding after using the Pringle maneuver, that might make you consider the hepatic vein or the IVC as sources instead, because there's still continued bleeding. However, if bleeding does stop after you've clamped the triad, now you're more concerned that it is a portal vein or a hepatic artery bleed. And on question stems, they really like you to they really keep it simple as far as differentiating between these bleeds. What they'll do is they'll give you, if it's a pulsating, bounding bleed that stops, that sounds more arterial in nature. And so if you see that on a question stem, you should probably pick something related to the hepatic artery. On the other hand, if it's more of a gradual oozing bleed that stops after you perform a Pringle maneuver, then that makes it more likely that they want you to pick a portal vein as the cause of the bleed. Okay, so now let's discuss the liver lobules and zones. And this is a good segue because the portal triad is very anatomically associated with the liver lobule. So remember that the liver receives blood supply through both the portal vein and hepatic artery. So how does that actually work in practice? Well, what happens is that the liver is set up in a way where you have countless lobules. And portal triads will border each of these lobules. So on the top right of your screen, you can see a portal triad. And what happens here is you have your common bile duct, you'll have your hepatic artery located here, and you'll have your portal vein. So the portal triad has now entered the liver, but now how does the blood actually flow through the liver? So what happens here is that we have a central vein, which I've highlighted in red at the center of each of these lobules. And blood will drain from that portal triad and percolate until it reaches the central vein. So you can see that both the arterial and the venous blood both will drain in this manner. And on the other hand, the common bile duct is actually receiving bile that's made in the liver, and this will ultimately flow down your biliary tract into your right and left hepatic ducts, your common hepatic duct, into your cystic duct, and into the gallbladder, and then it'll get excreted later on into your duodenum. Another thing I want you to recognize is the three zones of the liver. So the first zone it's named in the order in which portal fluid would reach the liver, essentially. So the one that's closest to the portal triad, basically the first one that the portal triad would ever encounter, is zone 1, sometimes called the periportal zone. Zone 2 is in the middle, it's called the intermediate zone. And then zone 3, sometimes known as the centrilobular zone because it's in the center of the lobule, that's the zone right here that's closest to the central vein. And so now I'm going to draw this in a pictorial format because sometimes seeing everything on a histology slide can be a little confusing, at least for me. Here I've drawn our portal triad and I've drawn our central vein. And remember that the blood flows from the portal triad into that central vein and the bile flows in the opposite direction. Now, this isn't the only portal triad and central vein in our liver. In fact, it's not even the only relationship in one hepatic lobule. What we'll find is that each lobule has one central vein, but it's surrounded by many portal triads. And these all are draining bile out into the portal triad and blood into that central vein. And keep in mind, we still have our 3 liver zones that I just want to mention. We have our periportal zone, which is closest to the portal triad. This is our most oxygenated zone, which should make some sense because our hepatic arterial blood has this is the first zone it encounters. And so as that arterial blood sifts through here, it's going to be high in oxygen in this early segment. So it'll be resistant to ischemia. If you ever have ischemia, we're going to find out later that like if you have shock liver, ischemic hepatitis, it's not going to damage zone 1. It'll most likely damage zone 3. This is the closest zone to incoming portal venous blood as well, as we know. And the relevance of that, recall that our portal vein system, it's not your normal vein system where it just goes through a capillary and then it goes to a vein. Really, the whole point of the portal vein system is to filter out any toxins that might have been in the GI tract that our GI tract accidentally absorbed, right? Our liver is more of a checkpoint just to make sure that anything that the GI tract absorbed is okay and safe, or it gets neutralized before it can enter our systemic circulation. The downside to that is that if there are toxins or viruses or what have you in our portal system, the first thing that's going to get affected is zone 1 and most likely to get damaged. Zone 2 is the intermediate zone. It doesn't really have too much clinical significance. I've heard a lot of not question banks, but I've seen a lot of resources that always mention that it gets damaged in yellow fever, and then they have this mnemonic where the two L's in yellow is like zone 2, essentially. I've never been tested on this, and I don't remember seeing any questions bank even practice questions on this, but something to keep in mind. Zone 3 is much more high yield than Zone 2, and so we'll go over what Zone 3 is all about, the Centrilobular zone, highlighted in yellow here. So this is the least oxygenated zone, which should make some sense because the hepatic artery has a lot of oxygen here, but as oxygen gets utilized by cells, there's going to be less available in this region. And so this is the most susceptible to ischemia. This has the highest concentration of cytochrome P450 enzymes. Remember that these enzymes are responsible for neutralizing and metabolizing a lot of products, including many of the drugs that people take. So here's a few enzymes. The downside to being the source for neutralizing all these toxins is that they're the most sensitive to damage from these toxins because they're interacting with them so much. So this region is at higher risk. This region also has the highest proportion of mitochondria in it, and because of that, you can see if there's ever toxins that specifically attack mitochondria, such as alcohol is a really good example, you'll see a lot of the effects in zone 3 first. So if you imagine if these purple things are our mitochondria and we have a lot of alcohol in our system, what can happen is that these mitochondria can die off and fat can start to deposit. And when we discuss alcoholic liver disease, I'll mention again that the fatty deposition typically occurs in zone 3 here, the centrilobular zone. This is the zone that's closest to the hepatic vein, which if you remember our framework of portal vein to liver to hepatic vein and then into the IVC, it makes some intuitive sense that the central vein is the closest to the hepatic vein. What that means though is that if there is a congestion, let's say there's a backup of fluid, the first thing that's going to be congested would be zone 3 and then zone 2 and then zone 1 in that order. So this will get congested right here. And here's another picture of that. Here's our hepatic vein in IVC. If the liver ever gets congested, zone 3, it will be the first affected. There's only, I believe, 2 cell types that really matter in the liver that they're going to test you on at least. I shouldn't say there's only 2 that matter. But the 2 that you should know for step 1 or level 1 at least are the Kupffer cells and the stellate or Edo cells. So the Kupffer cells are a specialized type of macrophages that exist in the liver, and they help clear bacteria and damaged red blood cells. And I like to remember Kupffer cells by copper cells. I think they're kind of the cops. They try to restore order. They're the macrophages that are trying to make sure everything's on the up and up. Stellate or Edo cells are probably the most high yield cell you have to know in the liver. When they're not doing anything, where they're kind of inactivated in their dormant phase, they help store vitamin A, but their real function or their real clinical relevance for our purposes is that when these stellate cells or Edo cells become activated, they like to secrete a compound called TGF beta. And TGF beta is known to cause fibrosis. So this can lead to hepatic fibrosis, which can in turn lead to cirrhosis and all of the complications associated with cirrhosis. So sometimes they'll give you this convoluted question where by the end of the question, you find out that the person has cirrhosis, and then they'll ask you the activation of which cell may have contributed to this pathogenesis. And the answer might be like the stellate cell. Thanks for watching. I hope you enjoyed the video. Please like, comment, and subscribe for more content.